Hi, everyone, and welcome back to another episode of Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today, we have the pleasure of speaking with Dr. Ann Peters, CMHC Co-Chair and Director of Diabetes Programs and Professor of Medicine at the University of Southern California in LA. If you haven't already, don't forget to rate, subscribe, and follow, and leave us a 5-star review. Thank you, everyone. Enjoy the podcast. Welcome to the podcast today, Dr. Peters. It's a pleasure as always.
It's great to speak with you.
Yes, and since we last spoke, which hasn't even been that long, so much has happened in the diabetes world. We are just coming off the 2022 American Diabetes Association meeting, where the big focus was about the treatment of obesity and type 2 diabetes and the data with Tirzepatide. Why is there such excitement about this agent, and what implications does it have for patient care?
I think what's so exciting about Tirzepatide is its potential for both weight loss and A1C reduction. And in the weight loss field, we really haven't had agents until the GLP-1 receptor agonists where we could really reliably work with patients and have them lose weight. And one of the things that's revolutionized diabetes management in recent time has been just that. And I've never been able to say to a patient, gee, with this agent, maybe you can lose 10 or 12 pounds. And with Tirzepatide, it may be double that. And I think that's really exciting. And everybody who's got weight to lose would like to do it in a way that works. And I really empathize with people who try to lose weight by dieting. I think it's possible to lose weight through conscious dieting. But I also think it's very frustrating for people, especially who've tried to lose weight and haven't succeeded, and try again. And I don't believe that all we need is medication. I believe we still need attention to lifestyle. But I think this makes it a lot easier for a lot of people to achieve their goals, or at least move towards their goals. It may not get people to their target weight, but it will really help them get closer. So I think it just builds on what we know and we've seen with GLP-1 receptor agonist. Now, another agent, one that is different than a GLP-1 receptor agonist because it includes GIP, but now we're going beyond what we already are familiar with and frankly comfortable with.
Does it help the patient to lose weight at a more progressive, faster rate?
Tirzepatide helps people lose more weight. And when I look at the curves for weight loss, it does seem to me to be relatively quick, but it also persists over time. So they did the studies for well over a year and watched people continue to lose weight and then gradually plateau. But it seems to work pretty quickly. Now, my caveat about this is I have patients who lose weight too fast and they start to look bad. I mean, this is not a medical problem, but they start to look really drawn and their faces lose too much fat and people get all panicked that they're losing too much weight. And I've had people have huge malignancy workups because of too much weight loss. So I think that ironically, one of the things here is that we have a very slow up titration because of GI side effects. So we start out at the lowest possible dose and then gradually go up. And I kind of like gradual things. So I don't want to see people's A1Cs go down from 11 to 6 overnight because I think that's not good and it may cause retinopathy. They didn't see that with Tirzepatide, but be that as it may, I like gradual change. So I haven't used Tirzepatide, so I don't know what it's going to feel like in my patients. But my suspicion is that I'm going to see them go down gradually. That's just my nature anyway, to give drugs slowly, titrate up gradually, and then see how people respond. So I think that the point here is that this has the potential for getting people down lower, getting them off their insulin perhaps or other medications, and the accompanying weight loss, which is likely to be better than we've seen with other agents. So I think it's a win-win, but I haven't used it yet, so I can't tell you what it feels like in an actual human. And again, I tend to go more gradually with treatments rather than boom. I don't want you to go from a very high number to a low number unless it's bariatric surgery. So here, I want to see them get better slowly and continue to improve their health habits.
And even though the ADA guidelines have emphasized obesity, the need for weight loss, and preventing weight gain as an important treatment consideration for several years now, it seems now that only this year, this approach has gained more traction and taking center stage. Why is that, and what has caused this shift, do you think?
I think we've always felt that treating obesity is very important in the management of type 2 diabetes, but we've never really had medications that were safe and effective. And yes, there's bariatric surgery, but to me, that's the sort of extreme. I refer patients to bariatric surgery who need it, but I'd prefer not to have patients need that if possible. So I think it's more that we finally have effective, safe ways to help people lose weight. And again, I think that there's always been an interest. I was part of the Look Ahead study where we looked at the benefit of weight loss and exercise in the management of type 2 diabetes. And even though we didn't meet the primary outcome, which was reduction in cardiovascular events and other endpoints, we did show along the way a lot of improvement in a whole variety of factors with weight loss. So I think that now that we can do it more easily and it fits in the algorithm because it's possible, I think it works. But I think a big problem is that if you're just treating obesity and not treating type 2 diabetes, it's in many places doesn't count as something that we can get reimbursed or get the medications reimbursed for. And I really think that not making obesity as something that clinicians, even in people without type 2 diabetes, can treat, I think it limits your thinking. I really think obesity is something we need to talk about much more broadly, looking at allowing patients to have medications that work and not to make it a problem, not to make it something shameful, but to make it something that we can help treat. Because when you treat obesity, you reduce the complications of obesity, and there are many complications of obesity that it would be nice to reduce.
Okay. And because tirzepatide was just approved in May by the FDA, where do you think it will fit in based on the data and evidence thus far? Do you think it will be more used for the treatment of type 2 diabetes or obesity?
I'm not sure how it will be more used, although I suspect it will be more used initially for the treatment of type 2 diabetes because I think it's more likely to be reimbursed. If it gets an FDA indication for obesity, that's great, but it all depends on who's going to pay for it because it's tough to get medications covered for obesity. The caveat with all of this is that we don't have the cardiovascular outcomes data yet. And I don't believe we're going to get it until the end of 2024. And we do have cardiovascular outcomes data on semaglutide. So I'm not going to switch somebody who has cardiovascular disease from semaglutide to tirzepatide because of a lack of cardiovascular outcomes data. So I am a little bit conservative in the sense that I know the benefits of semaglutide, and in the trials where they compare them, they only use 1 milligram of semaglutide, and now we can go up to 2.4 milligrams for obesity and 2 milligrams for type 2 diabetes. So I'm probably going to be conservative in terms of making sure people with pre-existing cardiovascular disease stay on an agent known to have benefit in that group and use tirzepatide and others where they don't have cardiovascular disease and they need a significant amount of weight loss. And one of the things that makes me happiest in life is getting people off a complex insulin regimen onto something really simple. And maybe I'll be able to use this in patients with type 2 who are struggling with insulin regimens and get them on this, and they won't need to take insulin, or at least not prandial insulin. I mean, there are all sorts of things I can imagine where this is going to help me manage diabetes. So we'll see. Again, I'm only as good as I know clinically, and I know the data from all this like we all do, but I want to now see what this feels like as we're treating patients. And then obviously it's a really expensive therapy. And all of the GLP-1 receptor agonists, and this is a GLP-1 GIP receptor therapy. So we've got to look at cost, and there are going to be people where they just can't afford these therapies. So we always need to keep in mind that as exciting as new things are, there are limits to utilizing it in all populations.
Those are some very practical, great points. What are some practical pearls clinicians should know about using this drug, both in terms of dosing and potential safety concerns?
As far as I know, there aren't new safety concerns with tirzepatide other than what we know from the GLP-1 receptor agonists. It's a new agent, though, and newer agents can have side effects that we haven't yet figured out. But so far, so good. I think that the bigger set of side effects are the ones we're used to with GLP-1 receptor agonists, which are the GI side effects. And those are dose related and really speak to the need to slowly up titrate this agent. And I don't quite know how they're going to do it, because is it every month we're going to have to write a wholly new prescription as we go up on the dose? Or they're going to give us a pack that has a bunch of different pens with a bunch of different doses. I don't really know what that's going to be like in actual clinical practice. But if I have to write a new dose each month, that's going to be something of a pain. And maybe they'll have a form where I can write, for 4 different doses all at once. Again, I don't know what this is going to look like. So from a practical perspective, I need to understand how I'll write the prescriptions. But the pen itself is really easy, and it doesn't require much teaching. So that part's really nice about prescribing these drugs to someone who's never given an injection.
And what do you think is more to come with this agent? And what are some additional pearls you'd like to share?
Well, I don't know what is going to happen, except that I can tell you that we're only getting better, and there are newer hormone combinations, and there are newer ways to look at trying to deal with obesity in a way that doesn't require bariatric surgery. And some of these combination agents are beginning to approach what we may see from bariatric surgery. So I think researchers are on the right track, which is to use gut hormones as a way to help regulate disordered eating and help people lose weight. So my sense is we should really encourage use of these agents. I would use them in people both with and without type 2 diabetes. In people with type 1 diabetes, I use them because they're obese and overweight, just like the general population, and it works for weight loss in people with type 1 diabetes, even though it's sort of an off-label use, but they don't say you can't use Wegovy, which is the branded name for the obesity form of semaglutide. They don't mention type 1 at all. So it seems to me you can use GLP-1 receptor agonists in people with type 1 diabetes who have an indication for obesity. So I think these can be used in almost everybody who needs them. But again, the issue has to do more with insurance coverage and how we can get them for our patients. But I'm a fan, and I think it's only going to get better in terms of our ability to safely pharmacologically help people lose weight. The, I guess, pearl of this, though, is that patients always want to stop things. And if they stop these agents, my sense is that reduction in satiety is gone and people get hungry again and they regain the weight. And so I want to make sure that it's okay to take something for the rest of your life if it's what's necessary to keep people at a more normal weight. So I try to set the expectation that, yes, this is something that you're not going to take for 6 months and stop, because I want people to adhere to it. And I always say, whatever happens, we can see what happens with your body. But these are agents that people are going to stay on for the long haul, at least from what I know from using them clinically.
Yeah, well, it sounds like it can be potentially life-changing, especially if they don't have to undergo a surgery. So, wow, very, very insightful and very interesting. Is there anything else you'd like to share with our audience today?
I guess the thing I would say is to not oversell anything. And not that we're into sales, but as physicians, as clinicians, we talk about these agents. And I think that there are many different reasons that people gain weight and that people are overweight and obese. And I really am sympathetic to that. And I have had patients where GLP-1 receptor agonist therapy has not worked, and they haven't lost any weight at all. And, I don't know what the mechanisms are. I think that there are many different reasons, underlying metabolic reasons and psychological reasons for weight gain. So not everybody's the same, and not everyone's going to respond the same. So I think that we need to say these can help, but not that they will help, because they won't in everybody. And I don't want people to feel like a failure if it doesn't work. So again, I use all of these drugs that can possibly help people lose weight in the context of improving their lifestyle overall, and then hope that this can make it easier and more successful. All you want is for patients to be successful, but not everything works in everybody. And that's a really important point to really, when you start with this, say this, we'll try this. Let's see if it works for you. So that would be my approach.
Absolutely. Well, thank you for all of your knowledge today, Dr. Peters. It's a pleasure as always.
Thank you.
If you have any questions or feedback, please feel free to email us at info@cardiometabolichealth.org or find us on our social media channels on Facebook at Cardiometabolic Health or on Instagram and Twitter at CMHC_CME. And if you haven't already, don't forget to rate, subscribe, or follow, and leave us a 5-star review. Until next time, have a great day, everyone.